research findings. First of all, thank you for your interest and participation in this final session of a very busy day. The moderator said that I would get a piece of candy if I speak well. Well, I get first installment of that payment, and hopefully I'll get a second one. Now the subject itself maybe is not very interesting, but I'll try to do my best. This panel cost me a jar of sweets. Yes, science is important. Okay, conflict of interest, the first slide, and the content, the outline. First of all, I'll talk about basic concepts, and then the evolution of ODD and irritability as a symptom in ODD, aggression in ODD, and of course diagnostic validity is also very important. So to what point do we place this condition, local data, further research recommendations and limitations. Okay, basic concepts. Now emotion and emotions, what are they? They are things which are autonomous changes which push us to perform certain actions. So autonomous nervous system change is an emotion. Our interpretations, remarks, actions, or impulses to take action. There is also what we call display rules. Socialization and maturity come into play at that point. It's about how we express our sorrow, anger, etc. Now our assistants know that when I'm angered I become polite but can bite, I call that. So this is my expression method. So what is emotion regulation? Emotion regulation is changing an emotional situation or regulating a situation to reach a target. So what is emotional irregularity? Actually, we have extreme or inappropriate emotions, rapid uncontrolled changes, affective lability, and abnormal attention to emotional stimulants. So what is anger? Anger is a means of coping with individual and societal problems, and it's the totality of physiological and psychological processes. In normative thresholds, it assures adherence, but it can, of course, go beyond those limits. Now, there is a distinction between rage and anger, in fact. Rage is the uncontrolled type of anger. Behavior is not goal-directed and out of control. I think this is an important distinction. Irritability is less well determined, so it's bored, easily irritable mood. Aggression, on the other hand, is the tendency to display any behavior that another living being, organism, should refrain from because it can be harmed. But there's aggression towards objects as well, right? That's a missing part, maybe. Violence is behavior towards an individual self to another one to a group in terms of injuring, killing, death, psychological disorder, developmental disorder, and neglect or threatening. So violence can be self-inflicted to others and between groups. Impulsivity is something that we check with self-reporting scales, but these scales sometimes do not cover impulsivity because it is multimodal. Impulsive action and impulsive decision making might be the two main distinctions. Impulsive decision contains not being able to delay things. Now, in new publications, there is also a concept called urgency. It is acting in a prompt manner, the tendency to act in this way in certain situations. And the American Journal of Psychiatry had a number of publications in 2014 about this particular point. Now, this condition has has a wide phenotype. In young people, how should we classify irritability? The discussion is going on since the 90s. We have narrow and wide bipolar phenotypes, and these are episodic, in fact. And the wide type is irritability plus overexcitation, overstimulation. Another important discussion is pediatric bipolar diagnosis. Is it going up or not? What is real bipolar? Between the United States and continental Europe, there is a difference in terms of the diagnosis. And how should this condition be affected? Now, irritability increases bipolar risk in children, and unipolar depression and anxiety disorders can also go up. DSM-5 brings us a new definition. Maybe it's been here all the time. Let's have a look at the diagnosis criteria. ODD and others. Now we're going to discuss this in tomorrow's discussion as well, so I'll skip this quickly. Let's have a look at the epidemiology data. DSM-5 says this can occur in 2 to 5% in the society and clinics, more prevalent in men. In 1 year follow-up, it's about 50%. Comorbidities, depression, anxiety disorders, and ADHD. We have Zehra from our team who is in the audience. In last year's ACAP Congress, I think you had 9 cases in your presentation, so there as well, attention deficits, anxiety, depression were comorbid situations. For ODD, the prevalence is average is about 3.3% pubertal, and men are predominant. APA is only reported for the United States, narrow phenotype. This is Kokkaro's review from 2012. It shows the prevalence of this condition, narrow and wide, and the phenomenon described as narrow and wide are seen here. And then I got curious, decided to do my own analysis. There is a certain degree of heterogeneity, but the numbers that are reported do not differ widely. Now, irritability, as far as symptoms go, where is it located in DSM? It is an original outlook of emotional irregularity. It's not specific to any disorder in DSM-4 or DSM-5, although we focus on it a bit more for this specific condition. ODD can have 3 separate factors. It has an anger and irritable factor. This emotional irregularity seems to be connected with that. But Stimguys has 2013 study. They looked at Great Smoky Mountain study values, data. They have depressive situations, depressive and irritable, and only irritable in depressive episode is 5.7% in this study. Depressive and irritable mood situations during depressive disorder is especially prevalent for girls. Let's have a look at bipolar disease. During the episodes, there can be irritable mood, according to DSM-5, separation anxiety. The definition is when there's an expectation of separation, the child can be irritable or angered. DSM-5 again, easily angered, tense, untriggered, verbal and non-verbal aggression, anger, and explosions, and others. Even in OCD, we have anger outbursts and rage outbursts. Let's have a look at ADHD. Emotional irregularity and irritability also exist in this disease. There is a societal sampling you see on the screen, Stingars and Goodman. They say that the prevalence is about 38%. In adults, we're talking about very high rates, between 34% to 70%. So in ADHD, emotional irregularity is widespread, it's lifelong, and a reduction in attention to emotional stimulus can be a reason, and the treatment of ADHD also corrects this issue, this problem, and this is the assessment or a brief summary of the studies looked at in this review. This is an interesting meta-analysis. In ADHD, it looks at aggression and emotion and reward issues. It refers to a problem in relation to these elements, and that these can contribute separately to emotion irregularity. Long-term follow-up has shown that certain mood characteristics can have a relationship with this condition. So what can be the parts of the brain that would come into play? Ventrolateral and medial prefrontal cortex, visual areas, limbic areas can all play a role. So we focused on certain symptoms, and let's have a look at aggression now. How do we classify? Certain researchers had an etiological approach, offensive or defensive aggression, or we can have proactive versus reactive aggression. In DSM-5, where is aggression? It's in borderline antisocial personality disorder. In reactive aggression, there is a threat and provocation perception and rage involved, and impulsivity is an issue, and affective ability comes into play. Proactive aggression is based on expectation for reward. It's planned and targeted. There is no threat or other situation. So reactive aggression and proactive aggression are separated from each other from this point of view. Let's have a look at diagnostic validity. Robbins and Guza had a study in the 1970s, or in 1970 they came up with certain criteria for the validity of a psychiatric diagnosis. They need clinical symptoms, lab work or biomarkers, diagnostic, differential diagnosis, continuity, follow-up data, heritability, and family-related data. These are all required. And let's have a look at all of these from DSM-5's point of view. Clinical signs. These children have complicated history. They can have ODD, lack of attention, anxiety disorder, depression symptoms, etc. Heritability. In the family, there can be anxiety, depressive disorder, and substance abuse, and they are similar to bipolar children. Lab and biomarkers. In children with other diagnoses, neuropsychological test results will be similar. Emotional stimulants are paid attention to, and there can be original divergences from this. Let's have a look at follow-up. The importance of age limits is not known. Symptoms can change with age. In adults, unipolar depression and anxiety can occur, and follow-up data is very limited, all from DSM-5. So where is differential validity? So there is still a lot that can be done. So what's the future for this diagnosis? There are bottom-up mechanisms and top-down mechanisms. Now, bottom-up mechanisms for emotion regulation. One is orienting to emotionally salient stimuli. 2, evaluation of signals for rewards. Top-down are parasympathetic response, allocation of attention to emotional stimuli. So where is this condition headed? Subjective feelings, appraisals, cognitions, or actions, impulses. Now, display rules. Is it any different in these children? It can be subject for research. In ODD diagnosis children or with other conditions, I would actually be interested in this field of research, how they express anger in the family environment, etc. Another subject of research, interesting again. This has to do with behavior of children during certain episodes. Parents and researchers evaluate these separately at 30-second intervals. And the children hitting their feet on the floor strongly, pushing something around, throwing tantrums or shouting is associated with a lower degree of anger, but screaming, hitting and throwing is these are associated with a higher degree of anger and tantrum. I think these come from Minnesota and Wisconsin, two different states. I don't know how this would apply to Turkish children. Let's have a look at local data. Now, in children with this diagnosis, frontal lobe tests, are they in difference? Now, the sample is limited. This is retrospective and based on scales, and we will see this in the next slide. But what is interesting is that in these children, anxiety level and tracing form B and tracing form B completion period seem to be correlated. So, should we instead have prospective and clinical data at the heart of this assessment? It would have yielded different results maybe. This is another study with more than 6,000 patients, 2011-2013. Irritability and tantrum seizures, tantrum periods cases were screened. We had about 600 patients. We excluded those younger than 6 and lost data. We ended up with 206 patients. We used different scales to assess these children, and then we used depression scale lower than 19, parent scale lower than 21, and ODD criteria. Those who do not meet ODD criteria, we considered them as potential patients, and we ended up with about 99 children. The treatment we chose for these children was that we followed girls with SSRIs and boys with other medication than SSRIs. This might be our inclination, but comparing this to other clinics might have yielded interesting results. Some recommendations for future research. These rules, can they change through socializing, culture and parenting methods? Can it change from culture to culture? And sleep, what's the connection with sleep? In Nepal, for instance, oppressing emotions and never angering is taught to a Buddhist child. How would they get angered? How would a Turkish child get angered? How would an American child do that? A study was published in Pediatrics in 2013. A group of pediatrics focused on a healthy group of children reducing their sleep period for about 20 minutes per week. Irritability increased, but at 30-minute reduction, irritability went down. So it can be another field of research. Let's talk about certain restrictions. One of the most important criticisms is that we may be thinking something physiological in nature as something pathological while trying to reduce diagnosis of bipolar. Will we not end up with increased use of psychotropics? Empirical evidence is more limited, and retest reliability is also low. I would like to thank you very much for your attention.